Okay, it's 1 o'clock, so I want to be respectful of everybody's time today, and thank you all for joining us for this media availability with an update on crisis standards of care and our operations at St. Luke's. I also want to wish everyone a happy Veterans Day, particularly those who have served or have families that have served in the military. Your service to your country has been noted and admirable. Thank you so much. So today, please mute your microphones and turn off your cameras for now if you haven't, other than Dr. Johnson and Sandy Gerke. So today we do have Dr. Frank Johnson, Chief Medical Officer, St. Luke's Boise, Elmore, McCall, and Sandy Gerke, Senior Vice President and Chief Operating Officer, St. Luke's Health System. Dr. Johnson and Sandy will provide you with some brief remarks about St. Luke's current operations, and then we will open the call to questions and answers. When it's time, please raise your virtual hand by clicking on the button and I will call on you. When you hear your name, unmute yourself, provide your name, news organization, and to whom your question is directed. You can also ask questions in the chat feature if preferred. So a reminder for those joining us, please mute yourselves now and turn off your cameras. And with that, we'll get started with Dr. Johnson.
Well, thanks everyone, and thanks for the opportunity to share some information around what's happening here at St. Luke's and in our community. I'll start as I always do by expressing some gratitude for our community and for our staff and teams. It's been 7 weeks now in crisis standards of care. That's really unprecedented. No other state, no other area has gone through that long a period of time of crisis standards of care. And some inspiring stories from our staff and team, some certainly inspiring stories from our community who has stepped up and helped support us in our efforts. And so there's at least been some bright spots in that crisis. There's nothing good about being in crisis standards, but really am grateful for the support from the community and the resilience and work that our teams have done moving forward. I'm grateful that our numbers and volumes are improving here in the last week. Really in the last week, we're seeing a reduction in our numbers of patients requiring hospitalization for COVID. That's fantastic news. Our hospital capacities continue to be high. Our volumes continue to be high. There's non-COVID patients who are now taking up our hospital beds to a greater extent, and we're working to care for them. We've been able to stand down many of our surge units and redeploy staff back to locations where they traditionally work, and that's all been fantastic. We've been able to restart some of our more urgent cases that we had to delay, and that also is great for our community. So some good news there. We are moving closer from being in crisis back to a recovery phase. And I'm using that term very specifically. Recovery is going to be really important. Our teams here in the hospitals have worked very hard over the course of the last 12 weeks, really, and more specifically, the last 7 weeks while in crisis standards. They've worked very hard to help our community recover and heal. And now, honestly, they're going to need a little bit of time to recover and heal themselves as we move beyond. We've had team members step up and take extra shifts, do work in ways that is very unusual for them. We've had people working in places that you might not even think about during a real surge like what we've had. We've needed to support our central laundry with a higher number of patients in the hospital. Laundry services were really strained, and we had staff members who went from their usual places of work to go over to our central laundry facility and support those people who are working hard to keep our laundry services in place. That's remarkable. Our environmental services teams, keeping our facilities clean, preparing rooms for patients, have worked extra hard. One of my friends that works on environmental services, Mimi, I think she was here every single day for almost the entire period of our crisis standards of care. I hope she was getting some time off, but it seems like I was seeing her all the time, and we had other people stepping in to help fill some of those needs as well. That's above and beyond what our nurses, our doctors, our respiratory therapists, and pharmacists have had to do. there's going to be some need for recovery and recuperation, and it's going to take a little bit of time to get through that. So I will ask for the ongoing support from our community as our teams go through that recovery and rejuvenation and reflect the fact that they worked hard for the care of our communities, and yeah, now they're going to need some time to recover. Grateful for the steps that we're making. Sandy's got some good information and specifics on some of those steps that we'll be looking at to move from crisis standards out to recovery, and I think that'll be really helpful. And then after that, I'd be happy to answer specific questions that you might have. Thanks. Sandy?
Great, thanks, Dr. Johnson. So it was back in September, as we made our request to the state relative to crisis standards of care, we really cited 3 main reasons why we were in need of the declaration. The first revolved around space, the second around staff, and the third around supplies. So as it relates to space, really where we saw ourselves is we were overflowing into multiple non-traditional patient care areas in our 4 main hospitals. Today, we have great news, and that we have started to back that off. We only have 2 overflow units open today. We've also been able to accommodate our emergency department patients within our emergency department space. You may recall that was another situation that we found ourselves in, was that our emergency departments were overrun and we were taking care and providing treatment to patients in our waiting room spaces. So we're no longer activating those particular patient treatment spaces. The other piece of this puzzle was that we were consistently providing care to our critical care patients in non-critical care areas of the hospital. So a patient that normally would have been on high flow oxygen and moved to a critical care unit, we were accommodating that on our medical surgical or our telemetry units. In addition, as you know, with being in overflow, our census or our occupancy was well above 100% as we were using our pre-op and our post-op areas to care for inpatients. We had overflowed normal adult patients into pediatric beds as well as into our medical surgical beds. We have backed off on almost all of that. So we are closer and closer to contingency care as it relates to where we're providing care for our patients within normal functionally equivalent spaces within the health system. The other piece of that really came down to needing to load level across our health system. And one of the things that we had done was to activate our critical access hospitals where they had staff and beds available. And we were load leveling and moving patients from our community hospitals to our critical access hospitals in order to find beds for patients. We're no longer having to use that as a means of load leveling across our more acute services. So those transfers are not occurring at the rate that they were occurring back in September and into October. As we look at the staff front, you may recall that we had redeployed over 300 of our staff from our non-inpatient areas, so our clinics, our surgical services areas, as well as some of our quality and patient safety areas and administration, frankly, back to the bedside. I'm happy to report that we're down to 36 of those staff members being redeployed. And it looks like coming up the week of November 22nd, all of those team members will be back in their home departments. That's allowed us to do a few things. One, our team-based care efforts and our ability to stretch ratios, we have been able to go back a little bit to normal operations. So we're still caring for a higher number of patients than we're used to caring for, but we're doing that with our traditional inpatient staff, supplemented with contract labor, as well as the staff that we received from the federal government agency that came earlier on. I think we had 190 of those team members that joined us. So those team members are continuing to extend through January, and some of those non-clinical team members are extending into the March timeframe. But when those staff have been deployed back to their home departments, we have been able to turn on many of our surgical cases. So we're slowly ramping back up our ability to perform those more still medically necessary, but not as urgent or emergent cases that we had been pulling off the books in order to make room for our other influx of patients. So that's super exciting. We do still have a backlog. We're estimating that it's upwards of 5,000 cases. And so we are continuing to open up that surgical services capacity across the entire health system. And we have case review teams in each of our hospitals that are managing that backlog and looking and evaluating where we have room, what team members have we been able to bring back to the surgical services area, what are their skill sets and specialties, and what cases have been waiting and who's been waiting the longest, and what does that look like, and how then will we begin to accommodate and work through that backlog. The other item that caused us to consider crisis standards of care was really around the equipment front. And we had ran out of hospital beds. So we were taking care of patients on gurneys. We were renting additional beds. We had ran out of ventilators. Our supply was able to be restocked, but we've also seen a decrease in the patients that are on our ventilators today. And so we're no longer using non-traditional ventilators to provide patient care for those patients in need. We had some on and off situations where our oxygen supply was getting to critical levels, and that too has been able to be corrected and accommodated. And while our personal protective equipment remains at target or above our target standards for the next 3 months in terms of what we project we will need, we are cautiously watching the logistics market, as we know many of the overseas manufacturers, as well as just the general transportation channels, have been strained. And so our supply chain teams are working with manufacturers, distributors, as well as securing additional offsite locations for storage to stock up on those critical supplies should we need them, or should we get into a situation where that supply chain looks to be depleted. So all in all, we do feel like we're hitting a little bit of some promising outlooks as it occurs and refers to our overall patient census. Dr. Johnson told you that we're seeing our volumes come down slightly, but we are still seeing our critical care volumes at levels that we would not normally be operating in at this time of the year, higher than what we would traditionally see during a normal flu season. So we are continuing to watch that closely and monitor where our capacity is, and make sure that we are evaluating on a daily basis, as well as looking at our 7-day rolling trend occupancy, how that looks to get to a more stable situation. And those are the big, I think, points that we had to share today overall. I will comment on a positive note that our vaccine compliance rate is above 99% for our team members, and for our providers, they are 100% compliant with our vaccine requirement. So everything looks great on that front, and you know that we opened pediatric vaccinations for the Pfizer vaccine earlier this week. We are holding clinics this weekend on Saturday, and we will administer nearly 1,000 pediatric doses this weekend. Those schedules have already filled up, and we are now opening vaccine appointments and schedules for next weekend, Saturday the 20th, and do still have appointments available within that time frame. And with that, Dr. Johnson, is there additional comments that you want to add?
I love your comment about vaccinations, and I would also share the message that the best thing our communities can do is to continue to get vaccinated, get your booster shots if you're elevated. That's the best way you can support your healthcare teams through these next couple of months. So thank you.
Great. Thank you both for those very thorough and really encouraging opening remarks. At this time, I would like to open it up to media questions, and please raise your hand, and I will call on you. And I do see that Andrew Bertline, you have raised your hand. Please go ahead with your question.
Thank you for setting this up. Really appreciate it. First question I'm interested in, you mentioned there's only 2 spaces right now, non-traditional spaces being used for patients. What was it like before, so we can just kind of get a measurement of the progress? Like, could you put that number 2 into perspective for us?
Yeah, definitely. Thank you for your question, Andrew. I'm going to go hospital by hospital so that you have a little bit more detail in terms of what that looked like for us. So at our Nampa facility, we had a non-traditional space open in our pre-op, post-op surgical services area for inpatients, and we were overflowing our emergency department patients into our cath lab recovery area as well as our imaging suites. So I would say that would be 3. Plus, we had a discharge lounge open and we were treating patients in the emergency room waiting area. In our Meridian department, sorry, it's been a long day already. In our Meridian hospital, we were overflowing into our mom baby area for traditional medical surgical patients. And then we had a discharge lounge open and emergency room overflow into the waiting area. In the Boise facility, we had an ICU overflow open in 2 different non-traditional critical care units. We also were overflowing into an additional 2 medical surgical non-traditional units for us. And then we did also have a discharge lounge open in that area. We did have our emergency room set up for overflow patients, and we're utilizing that as well. In our Magic Valley facility, we had 3 non-traditional medical surgical overflow units open, and we were utilizing many of our medical surgical and step down units for ICU patient accommodations.
Thank you. And then additionally, throughout the pandemic, we were hearing that large hospitals were actually relying on small hospitals a little bit to take on patients they couldn't handle. Is it the other way around now? If there's a smaller hospital that needs your help, does St. Luke's have the capacity to do that more traditional role, big helping out smaller?
Yes. So today with our volumes at where they are, we monitor that on a case-by-case basis, and we participate in a statewide call where we're helping other facilities, and they in turn were helping us load level across the state for when patients either needed critical care or other services. So today, those transfer avenues are closer to being back to normal, I would say. Dr. Johnson, what would you add?
I think you framed it up really well. I talked about a couple of the benefits of what we've learned through this pandemic. And from my perspective, the greatest benefit that we've learned is the value of collaboration and cooperation with each other, not just internally with our teams, we talked about that, but statewide and throughout the rest of our communities around Idaho. Through that Idaho mock call, and really full credit goes to our Idaho Office of Emergency Management team and the Idaho Hospital Association for helping to set that up. With those calls, we have developed some great relationships across the state to help each other out. We were sending during the last couple of months, we've been sending supplies to other facilities. We've been sending patients to other facilities from St. Luke's. And then we have also accepted the patients from those facilities when they've been in crisis. We've been able to rely on their assistance. We've worked out some great collaboration across the state. That's going to continue beyond the pandemic. We're going to be better able to help our state and help our communities moving forward as this continues to calm down because of the better collaboration and coordination we have. That's a great learning.
Thank you. And then last piece I'm interested, I'll get out of your way. Where's that? I had it written down. Oh, staff ratios. You talked about it a moment, staff to patient ratio. Sounds like it's getting better. What is the target number, and do we know where we're at? How close are we to that ideal ratio number?
Yeah, so the great thing that we've been able to leverage across our health system is that we do have so many resources as you look at our inpatient areas as well as our ambulatory clinics. And so while we've stretched technically our ratios, we've been able to supplement that with extra hands at the bedside with our team members. So for the most part, we've been able to maintain our traditional nurse to patient assignments. And when you think about what those traditional nurse to patient assignments are, in a medical surgical unit, it's 1 nurse to 5 to 6 patients. In a telemetry unit, it's usually 1 nurse to 4 patients. With an ICU, we average 1 nurse to 2 patients. All of those were stretched slightly to the extent at different times, many going up by 1 or by 2 in those situations. But again, we were able to bring extra hands to help those teams, whether that was our clinical nutrition teams, our certified nurse anesthetists, as well as even our managers and directors running and grabbing supplies and tasking and leveraging our virtual health environment to be eyes in the sky, as well as sign off on things that needed to occur in the room from a double check standpoint. So those nurse to patient assignments have pretty much gone back to normal at this point in time.
Thank you very much. I appreciate it.
Thank you, Andrew. Do we have additional questions from the media today? Ian Stevenson with the Statesman, I see that you have a question. Please go ahead with your question.
Thanks very much. So back in August and September, some state models and also hospital models were predicting surges in patients continuing perhaps through November. And from what we've seen over the past few weeks, it seemed that caseloads and patient numbers declined quicker than that. So I wondered if you all have any insight into why cases started to fall and why patients at your hospital started to drop when they did, and also whether you're expecting to see any further surges of COVID patients throughout the rest of the winter.
Yeah, I can take on that question, Sandy, if that's all right. Those predictions around what COVID is going to do, volumes of COVID, how it's going to affect are, of course, just predictions. It's we're still learning how this disease progresses and works its way through communities. And so that's not too surprising that the numbers weren't quite accurate in terms of those predictions that we would continue to see higher volumes through November. That being said, I think there's some reasons why we can point to the fact that the surge peaked and flattened out a little bit sooner than what those predictions suggested. We have seen ongoing increases in our vaccination rates across Idaho, and we know that vaccines work. We know that the vast majority of hospitalized patients with COVID are unvaccinated. And so as those vaccine rates increase, that only helps to reduce our hospital volumes. So that's one of the factors that influence that. We also know that infection prevention practices like masking works. We have seen some good pockets of increases in mask use during our crisis standards of care, and that's fantastic. So credit to those who were able to help get those processes going and help really slow the spread. I would point to those 2 factors as contributing factors. Different immunity in our population certainly makes a difference. I think there's some factor with that. But I would really point to the overall uncertainty of exactly how the pandemic surges, the increase in vaccination, and the acceptance of masking in the areas where it was accepted as contributing factors. Will we see another peak? I don't know. I think that's a great question. I certainly am optimistic, cautiously optimistic, that our vaccines will continue to keep things under control and that we won't see another surge like this Delta surge that we saw. Hopeful for that. I don't want to suggest that the mission is accomplished. We still need to be mindful of those infection prevention practices, be thoughtful over how we are interacting with groups and how we're working to protect our neighbors through the next couple of months. But I am cautiously optimistic that we're going to be continue to see COVID in our community. It's not going to go away. We'll continue to see impacts on hospitalizations and on our community, but that hopefully we won't see this dramatic surge again like what we saw this time.
Thanks very much. One other question regarding the vaccination requirements that you all have. First off, you mentioned that you're at 99% compliance with that amongst your team members. I was wondering if you're able to say what portion of those of team members have received some sort of exemption versus having gotten vaccinated. And then second, I wondered what the status of, I know that you all paused your corrective actions around that during this crisis standards plan. Is there a plan to restart those at some point?
Yeah, thank you, Ian. Like I said, we are at a little over 99% compliant. Our providers are at 100% compliant with the mandate. We have, through our human resources and our legal departments, evaluated and provided religious exemptions and medical accommodations. At this point in time, I don't have those actual numbers. And as we see those vaccination rates continue to increase, we have seen movement amongst some of our team members who had previously applied for an exemption or an accommodation, change their mind and end up getting vaccinated. So those numbers do continue to move for us, as well as the fact that we continue to onboard new team members every day. And that also contributes to our vaccine compliance. So I don't have those for you at this point in time, but our team is continuing to work through that. Relative to the pause on our compliance, we are down to less than 100 people, I think, in terms of that category. We, just like all of our other partnering healthcare providers, will be required come January 24th at the request of CMS to have that policy and fully vaccinated employees, with the exception of those limited religious and medical accommodations in place. So we are looking to make sure that we're coming up on that and that we're monitoring that closely. And I anticipate in the next few weeks, we will need to make some additional announcements and adjustments there for those team members that are non-compliant, knowing that the federal administration policy will be in place beyond what our pause was for. So December 4th or December 3rd, I believe, is the date that the Centers for Medicaid and Medicare are requiring the first vaccination to be done by.
Thank you.
Okay, thank you, Ian. Any other members of the press that have a question today, you can either raise your virtual hand or you can type it in the chat feature if you prefer.
Hey, well, we're waiting for a question to come up. Let me mention a question that I've heard from many venues and provide that, which is the effect of the delay in our surgery and other procedures on our volumes. Certainly, we've had to delay a lot of surgeries and procedures. I checked earlier today with some of our surgical leaders, and the estimate is that there's at least 5,000 surgeries and procedures that have been delayed. And getting caught up on those is going to take some time. That could take up to 6 months to get caught up on some of those procedures. We're working hard to get those done as quickly, as safely as we can, while still recognizing that that volume is going to have an impact on our already stressed teams and capacity. So trying to balance those things out, make sure we identify those patients whose needs are the greatest, that we need to get them done as soon as possible, move them to the front of the queue, and try to get through that backlog. It's going to be a challenge to get that done, but we've got a lot of people working on it, and I anticipate that we'll be making some good progress over the next couple of weeks and into the next couple of months on that.
Thank you, Dr. Johnson. I'm waiting to see if there are any other questions from the media today. Ian, I see you've raised your hand again. Please go ahead.
If no one else says, can I ask another one? Dr. Johnson, regarding the restarting of surgeries, you mentioned earlier that some of those have been able to be restarted. Are there certain categories that had been paused of types of procedures or surgeries that had been paused that are now being restarted that you can sort of go into specifics on, or is it more of a case-by-case basis based on prioritization?
Yeah, of course, surgeries that have been emergent, we have continued to perform those emergent surgeries. As capacity has allowed those surgeries that need to be done within a period of 2 to 4 weeks, we've been able to get those back going again as well. Of course, as we have delayed some of those surgeries, a procedure that might have been initially able to be delayed for 2 or 4 weeks, well, now we've been delaying surgeries for 8 weeks. So many of those surgeries have increased in urgency and have now been completed because of that. The surgeries that are delayed, the ones that are our biggest categories, there's many orthopedic procedures that have been delayed, knee replacement surgeries, hip replacement surgeries. Those are procedures that didn't have to be done in an emergent fashion, but they absolutely need to be done for the benefit of those patients who are suffering from the debility of a arthritic knee or an arthritic hip. So yeah, we've got to get those done. It's orthopedic surgeries. There's some spine surgeries that fall into that same category that we're working through. There are some different abdominal surgeries that still need to be done. Someone might need a gallbladder surgery as an example. It doesn't need to be done tomorrow, doesn't need to be done this week. It's not in crisis, but yeah, we've got to get that done in the next month. Those are the type of surgeries that may have been delayed that we really need to get going again at higher priority. We've had pediatric surgeries that have been delayed. That's just heartbreaking when you have kids who are needing to have a delayed surgery. We're working hard to get those done too. Some kids with urologic conditions, for example, that it's not an emergency. They don't have a current infection or crisis, but they're suffering. We need to get those surgeries done as soon as we reasonably can, and still do it safely. So. Bariatric surgeries would be another category that absolutely are important. Not a crisis that we need to help a patient with their their critical weight loss efforts through a bariatric surgery. But we need to get those done. Those are others that have been delayed. So I think those are many of the categories that we're talking about.
Thanks.
Yeah.
Terrific. Well, thank you all. I don't see any additional questions. So I thank everybody for their engagement and questions, and we look forward to our next connection.
Thank you.
Thanks.
Thank you.